After 40 years of operating on human hearts, more than 3,000 of them, I stopped performing surgery at 68 years old. Not because my hands lost their steadiness, not because I got tired. I stopped because I finally understood what I should have learned much earlier, that the busiest surgeon in the room is often the one who knows the least about when to put down the knife. My grandfather Mordecai used to tell me something in Yiddish while we studied the Talmud together in Warsaw after the war. He said, "Elias, a doctor who never says no is not a doctor, he is a merchant." I was young then. I thought he was being cynical. I thought all wisdom was about fixing things, about intervening, about doing. 40 years of watching people survive surgery only to wish they hadn't, that taught me he was right. I want to talk with you about 5 surgeries that I performed hundreds of times in my career. Surgeries that are still being recommended to people over 65 every single day in hospitals from here to London, and that I would never, under any circumstance, accept for myself. Not because they are always wrong. Medicine is not that simple, but because the system that decides when to recommend them has forgotten something very basic. The human being lying on the table has a finite number of days left, and some of those surgeries steal more of those days than they give back. This is not easy to say out loud. In my field, there is enormous pressure to intervene. The incentives are structured that way. The training is structured that way. The liability is structured that way. But when you are 72 years old and you look at your own mortality clearly, you realize that no hospital administrator and no insurance company will be standing beside your bed when you are dying. It will be you. It will be your family. And you will wish you had asked one simple question before they rolled you into that operating room. Will this surgery actually let me live, or will it just let me exist a little longer in pain, discomfort, and dependence? The first surgery I would never accept is the carotid endarterectomy, the cleaning out of clogged arteries in your neck that supply blood to your brain. This is one of the most commonly recommended surgeries for people over 65. The surgery itself is real. The blockages are real. But here is what the system does not emphasize. Decades of research, including massive studies funded by the National Institutes of Health, have shown that for most people without symptoms, the risk of stroke from the surgery itself is almost exactly equal to the risk of stroke from the blockage over the next few years. You are trading a slow risk for a fast one. You are trading something that might never happen for a guarantee that you will be cut, anesthetized, and have your blood flow interrupted. I operated on a man named Arthur from Brooklyn. He was 67 when his cardiologist sent him to me. Perfectly healthy. No symptoms. No history of stroke. But an ultrasound found a 70% blockage in his carotid artery. The cardiologist told him he needed surgery to prevent a stroke. Arthur was terrified. He came to see me, and I asked him one question. "Has your neurologist ever told you that you have symptoms of a stroke?" He looked confused. He said no. I told him to go home, get a second opinion from a neurologist, not a cardiologist, and come back only if a neurologist examined him and found evidence that his brain was actually at risk. He did that. The neurologist saw nothing concerning. 23 years later, Arthur is 89. He never had the surgery. He never had a stroke. He is still alive because he questioned the first surgeon who recommended cutting him. This is what the Talmud teaches in the tractate Berakot. The sages wrote that 1 hour of true repentance and good deeds is worth more than all of the world to come. What they meant was that life is not measured in length alone. It is measured in consciousness, in autonomy, in the ability to walk freely without numbness or weakness, or the fear that the surgery itself damaged you. After a carotid surgery goes wrong, and sometimes it does, people wake up with strokes that they were trying to prevent. They wake up unable to walk on one side, and the hospital says this is a known risk and there is nothing to be done. The second surgery is the stent placement for stable coronary artery disease, that is, clogged arteries in the heart when you have no symptoms or only mild symptoms during normal activity. I performed this surgery hundreds of times. The stent itself is a remarkable piece of engineering. But in the last 20 years, large international studies have shown something that was not clear when I was in my peak years of practice. For patients with stable disease and no symptoms, the stent does not extend life. It does not prevent future heart attacks any more than medication does. It does prevent pain during exertion sometimes, but it also introduces a new problem. Now you are on blood thinners for the rest of your life. You cannot skip doses, and if you fall, you bleed. If you need unexpected surgery, you bleed. Your quality of life has changed, and your life expectancy has not improved. Margaret was 68 when she came to see me from Manchester. She had pain in her chest when she climbed stairs fast. A stress test was positive. A cardiac catheterization showed blockages. The cardiologist recommended 2 stents. I explained to her that she had other options. She could take medications, beta blockers, statins, aspirin, that would reduce her risk substantially. She could walk instead of run. She could adjust her life to what her heart could handle at this stage. She chose the medications and walking. She said to me, "Dr. Cohen, I want to die with my blood the color it should be, without thinners, and with the ability to play with my grandchildren without worrying about bleeding inside my skull." 12 years later, Margaret is 80, and she is still walking, still hiking, still seeing her grandchildren. No stents, no bleeding, no complications. The 3rd surgery is the hip replacement for mild to moderate arthritis without severe limitation. This one troubles me in a particular way because the recovery is real and serious. You are breaking the strongest bone in your body. You are replacing it with plastic and metal. The surgery goes well 95% of the time, but in the 5% where something goes wrong, a blood clot that travels to the lungs, an infection that requires reoperation, a dislocation, you are not replacing something that was broken from an accident. You are replacing something that was worn down by living, by moving through decades of gravity and motion, and that you could have continued to move through with walking aids, with water exercises, with medication for pain. The ancient Jewish tradition understood something important about acceptance. There is a blessing for every season of life, including the season when the body begins to slow down. It is not a blessing for broken bodies, but a blessing for bodies in transition. I think of Samuel from Toronto, who was 71 when his orthopedic surgeon told him that his knee arthritis was advanced and he needed a replacement. Samuel asked a simple question: will this surgery let me do things I cannot do now, or will it just let me do things less painfully that I am already doing? The surgeon seemed frustrated by the question. He said the surgery would improve his quality of life. Samuel said, "My quality of life is fine. I walk 3 miles a day. I take medication for pain, and I can still dance with my wife, though more slowly. I will come back in 5 years if I cannot do these things anymore." Samuel is now 78. He has never had the surgery. He still takes medication. He walks. He has not had the complications that he worried about. He made peace with the fact that his knees are not the knees of his youth, and this peace is worth more than the surgery could give him. The 4th surgery is the prophylactic carotid surgery for people with blockages but no symptoms, which I mentioned already, but I want to address it differently. The real issue is not the surgery itself, but the system that recommends it. In my 40 years at Johns Hopkins and Hadassah, I watched the threshold for surgery drop steadily. In the 1980s, we operated on 80% blockages. By the 2000s, we were operating on 60% blockages. By the time I retired, some surgeons were recommending surgery for 40% blockages in asymptomatic people. This is not science. This is mission creep. This is a system where the payment incentive is to find disease and treat it, not to ask whether the treatment helps the patient. The Talmud teaches in the tractate Nadarim that one of the greatest sins is the sin of precision, of measuring things so carefully that you forget what you are measuring them for. A blockage that shows up on an ultrasound is real, but a person is not a blockage. A person is someone with a life and a family and a limited number of days, and some of those days should not be spent recovering from a surgery that was meant to prevent something that may never have happened. The fifth surgery is the routine valve replacement for mild aortic stenosis, a narrowing of the valve that lets blood out of the left side of the heart. This is a more delicate situation than the others because valve surgery in an older person does carry significant risk. The surgery itself has mortality. If it goes well, you may have 10 good years. If it goes poorly, you may have nothing. And here is what I learned that is difficult to say. At 75, 80, 85, sometimes a little bit of valve narrowing is not a disease to be aggressive about. Sometimes it is something to watch. Sometimes it is something to accept. Sometimes a person lives a reasonable life with mild valve disease, and an aggressive surgery shortens their life rather than extending it. This is the wisdom that my grandfather Mordejai shared with me. In the Talmud, the sages discussed the concept of pikuach nefesh, the idea that saving a life overrides almost every other commandment. But they also wrote that sometimes, in the case of someone very old or very frail or already near the end, the commandment to preserve life becomes the commandment to preserve dignity. They did not have modern surgery then, but they understood something about the human body that we have forgotten. There is a time when intervention is merciful, and a time when acceptance is merciful, and the difference between them is not always obvious. What does the modern system offer you instead? It offers you a pill that reduces your cholesterol. It offers you a simple blood pressure medication. It offers you walking, which costs nothing, and the research is overwhelming about its benefit. It offers you regular monitoring by a doctor who knows you, rather than aggressive intervention by a surgeon who does not. It offers you a Mediterranean diet, high in olive oil and fish and vegetables, which I recommend to almost every senior I have ever met. It offers you the opportunity to stay active, to keep your mind engaged, to move every single day. These are not glamorous interventions. They do not pay the hospital. They do not pay the surgeon. They do not require you to sign a consent form acknowledging that you might die on the operating table. They simply work. The reason that many seniors never hear about them is not because they are ineffective. It is because they are not profitable. A hospital makes nothing on the day you walk for 30 minutes. A surgeon makes nothing on the month you try a medication that reduces your heart attack risk by 30%. But these things save lives. They extend real life, not hospital time. So what do I tell you to do? First, if a surgeon recommends a surgery, ask for a second opinion from a non-surgeon. Ask a cardiologist, not a cardiac surgeon. Ask an internist, not an orthopedic surgeon. The structure of the recommendation itself creates bias. Second, ask yourself whether you have symptoms now, today, that limit your life. Not symptoms that you might have someday. Symptoms that limit your ability to do things that matter to you right now. If the answer is no, and the surgery is being recommended to prevent future problems, be very cautious. Prevention is valuable, but not all prevention is valuable to all people at all times. Third, ask what would happen if you did nothing. What is the actual natural history of your condition? Not the worst-case scenario, but the actual most likely course. Your doctor should be able to tell you this. I wrote down everything I learned in 40 years of practice, the things I did, the things I wish I had not done, the patterns I saw, the wisdom from my grandfather, and from the traditions I studied all my life, into a single practical guide. You will find the link in the description below. It is for seniors who are tired of being afraid, who want to understand their own bodies, who want to make decisions based on facts rather than fear. It is not expensive. It is not a scam. It is just what I know. The last thing I want to say to you comes from King Solomon, who wrote in Proverbs 17, verse 27, "Whoever restrains their words has knowledge, and whoever has a cool spirit is a person of understanding." This applies to doctors as much as to anyone else. The doctor who restrains themselves from operating when operation is not necessary, that is the doctor who has true knowledge. The surgeon who can look at a blockage and say, "Wait, let's monitor this. Let's try medication first. Let's see if you can do the things that matter to you." That surgeon is rare. But that restraint is wisdom. You are not a collection of statistics. You are not a billing code. You are a person who has lived 7, 8, 9 decades, who has loved and worked and raised children and built something in this world. Your remaining days matter. They matter more than a surgery that might extend them by a few months, if everything goes perfectly, and might end them if something goes wrong. Choose your interventions carefully. Choose doctors who know you. Choose to walk. Choose to live actively in the years you have left, not to spend them recovering from surgeries you never needed. This is what I would tell my own grandfather if he was still here. This is what I would tell my own children. This is what I am telling you now.